For this session, I invite Dr. Parul Bhatt, Dr. Anil Kulshresh, Dr. Nitin Parekh, Dr. Dharmin Balodia, Dr. Himanshu Meghnati, and Dr. Hussain Bhatia as respective moderators and chairperson. Respective chairpersons, do we introduce our speakers?
Dr. Anil is requested to introduce Dr. Bhupen Desai.
Very good afternoon. It's a pleasure to introduce Dr. Dhiren Bhai. Dr. Bhupen Desai. He did his MBBS and diploma in cardiology. He did his MD PGI Chandigarh, DNB, DM, cardiology. He's a fellow of American College of Cardiology. He's a fellow of European Society of Cardiology. He's an ex-Wadia, Bombay and Nanavati Hospital. He's an ex-cardiologist, LNT, Bristol Mayor Squibb Hospital, ex-senior cardiologist at Quintless Research. He had more than 27 years of experience in cardiology practice. He is at Holy Family BSES, Karuna Hospital, Mumbai. Inspiring Cardiologist Award he got from Economic Times. So very decorated CV. So without much ado, I will request Dr. Bhupen Desai to start deliberation. Thank you. Should I introduce all three?
Yeah. Please introduce Dr. Rashmit also. And
okay. So Dr. Rashmit Pandya is a senior cardiologist from our city, Ahmedabad. He is presently a senior interventional cardiologist at Apollo CVHF, Heart Institute SG Highway, and he has the rare distinction of having to credit the dual qualification of DM cardiology and DNB. He received a DM super specialty degree through Vijay Medical College. He is a research fellow in UN Mehta Institute of Cardiology. He has research papers, publications, and award and distinction. So, Dr. Rashmit Pandya is a very renowned cardiologist of city of Ahmedabad. Now to the next. It is again a pleasure to introduce Dr. Abhishek Rawal, who is from city of Rajkot. He is MD, DM Assistant Professor and Interventional Cardiologist at UN Mehta. He is specialization in cardiology, congenital heart intervention, interventional cardiology, and stress cardiology, non-invasive cardiology, and echocardiography. He has been at the faculty of the year at TCT Asia Pacific 2018, organized by Cardiovascular Research Foundation, Seoul, Korea. So, floor is open to start deliberation. So, case, should I read? The case is a 55-year-old male. His heart rate is 88 per minute. ABPM shows 152/98 millimeter of mercury. And his fundus shows hypertensive retinopathy grade 1. So I will request the speaker to start deliberation. What drug we should use? Yes, sir.
Yeah.
Yes.
Can you see my screen?
Yeah, we can see it.
My voice and my video is clear, right?
Yeah, very clear. Please go ahead.
1 second. I'll just make it in a slide. So we have a patient who is 55-year-old. His BP is 152/98. So BP is still uncontrolled. He's on at least 3 drugs. That is Telmisartan, chlorthalidone, and amlodipine. And plus his heart rate is 88 beats per minute. So this is the background which we have. And how best to treat this gentleman. So what are the issues we have? We have to reduce his blood pressure. At the same time, we have to reduce his heart rate, because in 2022, heart rate of 88 is not acceptable. And I'm going to discuss about this. So what choice do I have? I can increase the dose of any one of all the 3 existing drugs. He's taking 3 drugs, but they are not at full dose. I can increase the dose of any one of the 3 drugs, or maybe I can increase the dose of all the 3 drugs. Or what can I do? I can add a new antihypertensive agent. What will I do? Because increasing the dose of one medication is better than adding a new drug. What does the data show? This is the data from more than 11,000 participants from 42 trials, and it says very clearly extra blood pressure reduction from combining drugs from two different class is approximately 5 times greater than doubling the dose of one drug. So this gentleman is on 5 milligram of amlodipine. I can make it 10 milligram, or I can add something new, but then I will get 5 times more better blood pressure reduction. So doubling the dose of an existing medicine does not help much. And this is large data from 42 trials from 11,000 patients. So what can I do? He's already on diuretics, he's already on calcium channel blockers, and he's already on ACE inhibitors. So can I give beta blocker? Can I give alpha blocker? Or can I give a newer CCB? That is the most important question. Now we have decided that we will give him a new agent because we are expecting 5 times better reduction in blood pressure compared to doubling the dose of the existing drug. About alpha blocker, I'm not very greatly convinced because ALHA trial had shown that it causes increased mortality. It can cause postural hypotension, patient might fall down, and it will not reduce heart rate. Our target is also heart rate. What about newer calcium channel blockers? There are no convincing data. Amlodipine still remains the gold standard, and patient is already on amlodipine. So I would not like to disturb that also. So in my mind, I think there are two issues which we have to settle in this gentleman. We have to reduce his blood pressure to less than 130/80, which is the current standard of care. And we also have to reduce his heart rate. So what is the relevance of heart rate in the treatment of hypertension? As you can see this, look at this. Elevated heart rate is a predictor of cardiovascular outcomes. Resting heart rate, that is what we call it RHR. Resting heart rate is a predictor of adverse cardiovascular outcomes. As you can see from this slide, which has compared people with heart rate of more than 70 and people with a heart rate of less than 70. And head-to-head comparison has shown that fatal and non-fatal MI significantly increases. Need for coronary revascularization also increases in persons who have a heart rate of more than 70. And most important hard point is cardiovascular death also increases if your heart rate is more than 70. So we have to bring his heart rate to less than 70. Patients with a baseline heart rate of more than 70 have a significantly higher risk of all cardiovascular events. Heart rate is the key determinant of myocardial ischemia. We all know about it. The heart rate increases, ischemia risk also doubles up. And look at this data. This is the data of different heart rates and mortality rates in normotensive as well as in hypertensive. So let us discuss about this hypertensive patient. Look at this saffron bar. Hypertensive patient who has a heart rate of more than 80, he falls in this category. His heart rate was 88. His heart rate falls into the saffron bar. So increased heart rate causes more deaths per 1,000 patients. All-cause mortality is increased. Cardiovascular disease mortality increases, and coronary heart disease mortality also increases if your heart rate is more than 80, like this gentleman has it. And we all know that this is a large data from INVEST study, which analyzed 22,000 patients who had underlying cardiovascular disease. They were all hypertensive, and they were followed up for a period of 2.7 years. And as you can see, as the heart rate goes above 80, the hazard ratio starts rising. Look at this yellow line. This hazard ratio starts. Our patient falls into this category. So it's a significantly higher estimated hazard ratio for adverse outcomes, including death. We need to control not only his blood pressure, but also his heart rate. Higher baseline and follow-up resting heart rates were associated with increased adverse outcome risk. We all know about this. And this is the data from India. It's a paper published by our own Dr. Jamshed Dalal. And he says that resting heart rate is important. And this forum, that is this Dr. Jamshed Dalal's Asia Pacific Region Forum, recommends that resting heart rate should be considered as an independent risk factor for cardiovascular events and mortality. Country guidelines should be updated to include resting heart rate monitoring, and pharmacotherapy should be considered in high-risk hypertensive patients with elevated heart rate. Controlling blood pressure is only half job done. So how can we do this? How can we help this gentleman? Beta blocker is the key in my opinion. To conclude my talk, because I've been allotted only 10 minutes, to conclude my talk, I would say that heart rate is a risk factor for cardiovascular mortality. Again, I would repeat, resting heart rate is a risk factor for cardiovascular mortality. It is independent of other major conventional risk factors like smoking, diabetes, and hyperlipidemia. Heart rate should be used to assess the overall cardiovascular risk, and it should guide us to provide a tailor-made therapy for our patient, like this gentleman who has BP was high and heart rate was 88. Beta blockers have documented efficacy in reducing heart rate, blood pressure, and also in improving the outcomes of patients with hypertension, including those at high risk of cardiovascular risk, like coronary artery disease, heart failure, and in diabetes. So controlling blood pressure without controlling heart rate is not acceptable in 2022. Thank you so much. I will rest my case here. Thank you. Dr. Anil, you are mute.
Thank you, sir, for giving a very decent presentation, excellent presentation rather, and very forceful. So
Yes.
beta blocker is the key. Now let us listen to the next speaker who will be talking about alpha blocker.
Okay, am I audible?
Dr. Pandya, yeah, Dr. Pandya, please.
Yeah,
go ahead.
Dr. Rashmi. Please
Hi,
go.
sir. How are you?
Very well.
Fine. Sir, I'll directly go to the presentation.
Yes, yes.
Rashmi, you look great.
Oh, thank you, sir. I would rather prefer doing great procedures. Okay, is my screen
Yeah, yeah.
visible?
Yes, yes, it is. Yeah,
Fine.
you can see it.
So, okay, I'll initially I'll clarify the case given to me. The heart rate was like mentioned 80 beats per minute. So if really this gentleman has 88 or 90 or something like that, I would certainly also think about beta blockers. But if the heart rate is say bit okay, bit 70, between 70 to 80, then I certainly would like to examine other possibilities, other kind of medicines which you can use in certain kind of patients. Now, I'm not going to details about these things. This is already an uncontrolled hypertension patient. We would rather not label him resistant right now because he's not on the optimum doses of all the medicines. But we all know that there are, as sir had already said, the heart rate is independent predictor. Much more is the level of blood pressure. Whatever level of blood pressure you have, even a 2 millimeter mercury decrease in systolic blood pressure would lead to a remarkable and drastic decrease in the heart disease mortality and also risk of strokes. So if we look at the combination therapies, as it is obvious from the guidelines in India also, we are more prone to combine the more evidence-based medicines, and it is also true. But if we see beta blockers, they are hardly recommended as first-line treatment, even second line, not even second line. Some guidelines even have pushed them down to fourth or fifth because of few important risks that we have come across in recent years. And major reasons will be two. One is the increased risk of new onset diabetes, especially when it is used in combination with a thiazide and also with an ACE inhibitor. So here the patient is already on ACE inhibitor and thiazide. And if I think of putting this patient on beta blocker, then the risk of new onset diabetes is going to be exponentially high. So that thing I must have to keep in mind and keep the patient in constant follow-up. That again is a major problem with our patients who just forget to come to follow-up and they turn up after 3 or 4 or 5 years, and you may not be able to check his or her blood pressure and even the sugars regularly. The second reason is compared with other agent, beta blockers generally are less effective in reducing cardiovascular events, especially stroke. In few studies, even stroke rate was noted to be higher in those patients treated with beta blocker, particularly because they increase the central aortic blood pressure, and which translates into increased amount of stroke. If we see the various trials, beta blockers, diuretics, when combined, they definitely lead to much more increase in diabetes. I am not going to too much of detail. These are all available, but it is a known fact. And combined with ACE inhibitor and diuretic, they are going to be a disaster. Now, if we look at the ALLHAT trial, as sir had already mentioned, this was the chief trial which resulted in setback for alpha blockers in hypertension patients, because in ALLHAT trial, we registered a remarkable increase in heart failure. It was not particularly mortality, but it was the heart failure rate which increased almost double to that of the other agents. Now, if this, because of this, even this arm of the trial was stopped prematurely. Then there were many meta-analysis and scrutiny why this happened. because doxazosine is known to reduce hypertension to a very remarkable level. So then after many researches, we have come to know that it was probably because of counteraction by the body, which increases the body fluid. So fluid retention in the doxazosine arm, that was probably one of the chief reason why these happened. So whenever we want to use alpha blocker, then you may need to increase the diuretic dose or keep a tab on patient's weight regularly. That is what we have concluded. But the as a third line therapy in a very major trial, ESCOT BPLA, this was again powered on. This was specifically to examine whether the heart failure increase is real or not. And here we found out that the blood pressure lowering by the alpha blocker was to the tune of almost 12 millimeter mercury in systolic and 7 in diastolic. And we are all aware, most of the major drugs, they produce a very modest decrease in the blood pressure to the tune of maybe 5 or 7 millimeter mercury. So they are very impressive agents, pushed back because of 1 or 2 negative trials, but there are many important follow-up trials which we many times forget to take a note of. So if we see the ESCOT BPLA, the heart failure rate incidence, if you see, it is almost similar to that of placebo. So alpha blocker, this was again a very major and large trial, and this was actually specifically designed to see. So we have to understand. So if we, I'm not going through this slide, there are many guidelines which clearly show that any individual having significant risk factor, particularly early CKD, the blood pressure has to be brought down to good levels, maybe 130 to 80 or lower if patient can tolerate. So I'm not going to that details. So initial 3 combination as this patient is receiving, I am completely agree with the regimen which patient right now is going on with. But if we see the alpha blockers, when everything fails, there are all the guidelines when blood pressure is not controlled, say with ACE inhibitors, say ACBs or beta blockers or diuretic or whatnot, then the alpha blockers are brought in to reduce the blood pressure. So now it is there is no disagreement that they are not effective in reducing the blood pressure. Beta blockers, on the contrary, they reduce, they increase the diabetes and stroke both risk. As we are aware, alpha blockers reduces blood pressure remarkably, but with that also proteinuria is remarkably reduced. The lipids are brought down to a good level. And in this patient, as we have seen, the serum creatinine is already 1.6. Patient is early CKD. So this is the patient where you would certainly like to reduce the blood pressure to a more suitable level. And alpha blockers just do that very effectively. Only incidence of this heart failure, which I have shown in 3-4 trials, I'm not going to details because of the time constraint, but in post ALHEART, there are at least 2 or 3 major trials where the stroke and the heart failure, both incidence has not shown to be as much as the projected in the ALHEART trials. So we have an agent which is very effective in reducing the blood pressure, neutral on lipids, neutral on sugar, no increase in the diabetes, no increase in the heart failure, contrary to what was suggested, and it reduces the proteinuria. So again, this is one of very important thing which makes our case very strong for the alpha blocker here. The albumin creatinine ratio. This again is a very important parameter, and in this ESCOT BPLA trial and many other trials, this also is shown to be significantly reduced with alpha blockers. So this was an early trial, echocardiographic trial, where ejection fraction is shown to improve in those patients having congestive heart failure. So we should not be wary of using alpha blocker in a patient where patient is already on 3 drugs, particularly if the heart rate is just okay, say 80, I would be okay using alpha blocker. 90 or something, then certainly beta blocker is one of the choice. Another choice in this patient would have been aldosterone antagonist like spironolactone. But in Indian patients, we do have to keep in mind that they, as I said, do not turn up frequently for follow-up. And if you are using spironolactone or eplerenone, then this patient needs to be monitored for hyperkalemia every 3 months at least. So if that patient is not able to follow that schedule, then it is probably better to go for some agent which is more safe. So already 3 drugs, including acetylpyridine diuretic, CKD is already set in. Heart rate is not too high as per given to me, it was 80. So in this case, we certainly have to think about small dose of alpha blocker probably would do wonders. Thank you.
Thank you, Dr. Ashmit Bhai, for giving a very illustrative discussion on this alpha blocker. Alpha blocker actually late 90s, rather late 80s, Dr. Kaplan, he was very fond of promoting alpha blockers. And unfortunately, it could not stand for long.
Based on only one trial. Based on only one trial.
Abhishek.
Yeah.
Yeah, yes, please.
Dr.
Hello, may I audible? Hello?
Yes, Abhishek, you are audible.
Yeah, please allow me, someone please allow me to share my screen.
Dr. Rashmit, you have to stop sharing first.
Yeah, I am extremely thankful for this warm introduction as well as warm welcome. In addition, I congratulate Dr. Desai sir and Dr. Rashmit sir for their wonderful presentations, which made my job.
Dr. Abhishek, you are
easy.
not seen on the screen.
Yeah, just
Your
a minute.
video is-
Let me share the screen.
Yes, now your
Yeah, so
video is open, but you are
yeah,
not.
so please,
Yes, that's right.
yeah.
There is a lot of background sound.
Yeah, there is a background
Yeah,
noise,
so-
and also we need your slides to be shared. We can't see your slides, Abhishek.
Actually,
Abhishek, we can't see your slides. I think we have network issues with you.
yeah, so I opened the slides. Are these slides visible?
No, you need to share them. Please click
Yeah,
on
so
the
if
share screen button below. Are you sharing?
yeah, otherwise, I have shared my presentation.
No, it's not. Then probably you need to reshare. Yeah. Stop sharing and then again click on share screen and then go share your slides.
Yeah, otherwise, may someone from technical team share? I have sent the presentation to them also.
Yeah, sir, please share on cardiac mail ID.
You've shared where, on which ID? On the cardiac email ID, Abhishek?
I have sent to that technical team numbers.
It's on the WhatsApp?
Yeah.
Yeah, Neelam, please do needful. In the meanwhile, we can have some discussion chairpersons for the 2 presentations so that we can save time.
The discussion can be preponed. Rashmit and yes.
Dr. Dharmin?
Dr. Bhupen and Dr. Rashmit. Yes, please go ahead with the discussion.
Yeah, I think in this patient, the beta blocker would have been the ideal choice. It was a clear-cut case for a beta blocker. Who had a beta blocker.
88 beats per minute. I agree, definitely.
Yes, sir.
Doubt. But I'll also like to comment about exercise. Here in this patient, if you want to bring down the heart rate, it would be much more prudent to prompt this patient for doing.
So we have Abhishek slides here. Abhishek, you can go ahead with your presentation. We will come back to discussion. You have to just say change next slide and then she'll do. Next slide, please. Abhishek, you need to unmute and go ahead. You're muted, Abhishek.
Yeah. So this is the summary of our case is a 55 years old male with tachycardia and uncontrolled blood pressure on ABPM. Patient is having end organ damage. However, he is on a suboptimal dosages of ARBs, calcium channel blockers, and thiazides. In addition, clear that the function has not been mentioned in this case. So I think from that point of view, patient is stable. Next slide. Yeah, so this is the sprint trial who emphasizes the control of systolic blood pressure to less than 140 and diastolic blood pressure to less than 90, which reduces the significant morbidity and mortality. Next slide. So this is also emphasized in JNC8 as far as the gold blood pressures are concerned. Next. Next slide. Next. Yes, someone please change the slide. Yeah, so I'll emphasize the roles of different guidelines in decision making regarding the selection of antihypertensive therapy. So this is a JNC8 back slide. This is the JNC8 where they emphasize ARBs and calcium channel blockers and ARBs in the primary treatment. Next, diastolic less than 90 and systolic, please.
Abhishek, your voice is not clear.
Yeah, next slide, please.
Jayesh bhai, there is a lot of background.
Now, yeah, so this is the slide of my presentation with within 1 month of treatment, we should optimize the dosage, and the selection class would be according to the recommendation 6 that thiazide diuretics, calcium channel blockers, ARBs or AC inhibitors. And if the blood pressure is not controlled, then we may either optimize drug simultaneously or sequentially. So JNC7 and JNC8 not specifically mentions the other class of drug as a primary treatment, and they have asked to add the alpha blockers as well as aldosterone antagonists only when the optimum dosage of these primary drugs have achieved, and which is not in our case where our patient is not on the optimum dosage of other antihypertensives. So we need to optimize the these classes, as well as we may change the molecule amongst these classes prior to switching over to other molecules like beta blockers, alpha blockers, or others. Next slide. In addition, regarding the beta blocker, I am totally agree with Dr. Desai sir regarding the role of beta blocker for the control of tachycardia. For the control of tachycardia, and the tachycardia of 88 as a resting heart rate is not permitted. But still, as far as the antihypertensives are concerned, the panel of JNC8 does not recommend the beta blockers for the initial treatment of hypertension when the other drugs are not optimized. So this is because the beta blockers are increase the primary composite endpoint of cardiovascular death, MI, stroke, compared to uses of ARBs or other antihypertensives, and with increment in central blood pressure, these beta blockers may lead to increment in risk of stroke. So as per the JNC8, the role of beta blocker sole as an antihypertensive, which is required in this patient, is not supported. Next slide. So this is the guidance algorithm, and the red mark box suggests that we may maximize the first medication. Like first medication in this case may be either a CCB telmisartan 40 milligram, which we may increase to 40 milligram, 80 milligram, or we may change to other potent ARBs like azilsartan, etc. Or we may, or if we are considering amlodipine as the first medication, then we may either make it to 10 milligram a day or 10 milligram twice a day, or may switch over to some newer calcium channel blockers who are highly potent like benidipine, efonidipine, or ezilnidipine, rather than switching over directly to alpha blockers or beta blockers. Or we may optimize the both drugs simultaneously. Next slide. And this JNC8 as well as previous JNC7 guidelines both suggested aid and titrate, and this is the more emphasis given to titration of ACMTOs, ARBs, CCBs, and diuretics, etc. These are of drugs rather than adding. Next slide. This is also showing the same that aid and titrate. Next slide. Hello, someone please change. Next slide. Next slide, please. The optimization of these primary drugs, because primary drugs are more proven as far as the control of hypertension is concerned, as well as risk reduction is concerned. This is the another guideline which is also newer as compared to JNC8, and this is a minus slide. Back slide. Previous slide, please. So ESC guideline was also suggesting of control with these primary drugs. Antagonist was recommended is potassium sparing diuretic, which is extremely helpful to counter the breakthrough resistance and control the blood pressure. So European guidelines also supported AC optimal tolerated doses of AC inhibitors, ARBs plus CCBs plus thyroid like diuretics are beneficial. So NICE guidelines are also suggesting of optimizing the primary drugs. Other different guidelines are also considering these primary antihypertensives as primary drugs and beta blockers as a add-on therapy after optimization of these agents. Next slide. So regarding we may either optimize these agents like benidipine, which is highly potent, and we have experienced that 4 or 8 milligram of benidipine may control the blood pressure in most patients. Other important molecule in antihypertensives as far as the CCBs is concerned is efonidipine, which apart from blocking the L type of calcium channel blockers, which amlodipine blocks, is also a potent blocking agent for T type of calcium channel blockers. So, which is more the micro vessels, capillary vessels as well. So it leads to alleviation with amlodipine. GI disturbances are lesser. Next, in addition, amlodipine has also beneficial effect our patient is having by controlling the sympathetic cut down, which is may not be as effective
Abhishek, your voice is not coming. Abhishek, if you can listen to me, your voice is not there. Kindly unmute your mic.
I think he has a net issue.
Abhishek, unmute your mic.
Sir, he is left from this meeting. तब तक हम डिस्कशन कर रहे हैं चालू रखिए.
I think it is better we start discussing because there is some problem with the Abhishek's mic and other things. So let us start discussion. Abhishek, you can join in the discussion. You can give your views and everything. Anil bhai, is it all right now? We can start discussion.
Yeah. It is better. I think we should discuss this patient in toto rather than going for what you will do.
Abhishek has a lot of communication problems.
So there are three options, as I understand. One is beta blocker, other is calcium channel blocker, or third is titrating on alpha blocker. So as far as I think my experience goes, and I think most of the people will agree, amlodipine is still the most powerful CCB rather than this newer agent. They may be having less side effect, but most of these newer CCBs, they are not as potent as amlodipine, especially if you use in the full dose, that is 20 milligram. And alpha blockers nowadays you use as a last step. Only, I think the best.
Let us take opinion of Dr. Bhupen Desai and Dr. Rashmit Pandya.
Yeah.
And Mahadev bhai is also there. He can also give his expert opinion. And you are also there. So there are so many. Dharmin is also there.
Yes.
So let us start discussion.
Yes.
Meanwhile, Abhishek, you can also join.
In this particular patient, small dose of beta blocker would have solved all the issues. Alpha blocker like prazosin are quite difficult to tolerate. It may cause many side effects, like it may increase the resting heart rate and cause postural hypotension also. So it might create a new problem rather than solving already having one.
Yeah, I agree. At 88 heart rate, beta blocker is, that is what we usually practice. But if the patient's blood, say heart rate is in the range of 70, then probably it would be good. Then again, another choice would be spironolactone inhibitor, spironolactone, like that. I think that also is a very, very important drug, which many times we forget. Another thing in this patient which we can do is we can sometimes switch over if this patient is not on optimum doses of any medicine. So like to increase all those doses. I am not at all for any new agents, any benedipine or these and that dipine and sartans. Unless they are tried and tested in large clinical trials, it is none or null for us cardiologists. We cannot do that.
Yes, bhai, can I say something here?
Rashmin, Dr. Abhishek has just joined. Abhishek, you unmute your mic and give your opinion. Abhishek. Okay, meanwhile, Mahadev bhai, you please go ahead. I think
Abhishek was just to.
Abhishek, you can give your opinion loudly.
Yeah, I was. Yes. Yeah. I was just to emphasize the status of the guideline like JNC8, NICE, and ESC, adding the beta blockers or alpha blocker kind of agents, sold as antihypertensives. We should optimize the dosage of CCBs, ARBs, and thiazides. So we may increase the dosage in this patient of Telmisartan, amlodipine to the dosages which has been studied in trials. And if we can't achieve the targeted blood pressure with optimizing the dosage of switch over to either newer agents, or we may add the beta blockers or alpha blockers. However, still I suggest that we need to optimize and titrate the primary drugs rather than going to other newer agents.
Okay, Dr. Madhav, you wanted to say something?
Yes, thank you very much, Dr. Jayasbhai. I think there is no question that beta blockers is definitely the drug to be preferred. The question is whether you are which side of the table when you are discussing. When you want to say about against beta blocker, you use old beta blockers like atenolol or something, which have been proven to have side effects. But the newer beta blockers like bisoprolol or nebivolol definitely are much better, and they are not the same beta blocker that we used to see with the side effects. So I personally feel, and as we see that the use of bisoprolol and nebivolol is definitely the one which is going to help a lot in all such patients.
Dr. Rashmit Bhai, you wanted to tell something?
Yeah, as I clarified in the start, only if patient is having tachycardia, it is not acceptable, and we need to reduce it down based with either nebivolol or bisoprolol as Sir has said. That is, I would definitely like that. Only if the patient's heart rate is controlled and still blood pressure is not controlled, then we should not shy of using alpha blockers. As a cardiologist, we get a fairly large number of patients where blood pressure is not controlled with many agents, and there these alpha blockers and even clonidine, which is left out in most of the trials and discussions. These things are not bad. We can use them. Definitely use them.
In alpha blocker, what is your preference?
Prazosin.
Okay, Dr. Bhupen Bhai is there. Dr. Bhupen.
Yes, sir. I'm there. I'm very much there.
Dr. Bhupen.
Yes.
You want to tell something else?
No, I think I have convinced you all that everybody has agreed that this patient requires beta blocker. I think Dr. Rashmit Bhai spoke about the role of alpha blocker. I fully agree. If your heart rate is less than 70, there is no point in adding beta blocker. It will cause more harm. But in current clinical practice, I think alpha blocker comes as a fifth drug. I think after you use first three-line drugs, the first choice, particularly in India, becomes beta blocker. We are all little hyper people, you know. We have increased sympathetic activity in our population. Our resting heart rate in a normal population is 82 or so. There is one study called India Heart Study, and which have found that Indian people do have a higher resting heart rate because we are a little high in our sympathetic overactive. So beta blocker is very, very important in my opinion. And whatever things spoken about beta blocker against it, right? Increased incidence of stroke or increased incidence of diabetes, they are with atenolol, not with, I fully agree with Dr. Mahadev Desai, that they are with atenolol. Because of atenolol, we got a bad name for the beta blockers. So newer drugs like nebivolol and bisoprolol are too good. I mean, I would say bisoprolol is a very good molecule. We must use it more frequently in our population, though it has not come into guideline because there are no big randomized controlled trials. And that is why it has not become a part of any guidelines. But absence of data does not mean the drug does not deserve its right place. And guidelines are not guidelines. Guidelines are not guidelines. We have to use our own clinical judgment. And we can use in our population beta blocker. In fact,
our president, Dr. Anil Bhai, APS president, also wanted to tell something.
Yes, sir.
Anil Bhai, your mic is mute. Your mic is mute. Yeah.
Bisoprolol basically is a very old molecule. It's not a new molecule. And unfortunately, it is a European molecule. So it was never used much in USA. That is why bisoprolol is used less. Otherwise, it's a wonderful molecule I have used for last 30 years almost. And it has given a wonderful result. So
yeah, from bisoprolol, we are publishing our own tenacity investigator-initiated study, which is part of the e-poster today. in the session we've published, and it's going to be published in European Art Journal as well. We have looked at in acute coronary syndrome. However, it's not in the settings of hypertension, but because you were mentioning about beta blockers, I think heart rate is an important determinant here. But for alpha blockers, we do have a strong role, especially in patients with CKD and patients with already having diabetes. These two are the subgroups where you can still not completely rule out alpha blockers, and newer CCBs do have good evidence as far as eGFR and kidney protection is concerned. But I think CV outcomes, as I think both the speakers, Bhupen and Rashmit Bhai, pointed out, is something that we probably will have to look as the time comes and the data evolves.
So,
because there are many agents, many drugs which they come and go. They come with a big O and then they are thrown into dustbin because of many side effects on all these. So any new agents, whatever, however promising it is, unless it is shown to be effective and safe in large trials, we senior consultants would definitely be wary of using them.
Yeah, I fully agree with you. There are no convincing data about any of the newer CCVs or any of the newer ARBs. There is no convincing data. I think they are marketed in India because this regular drug like amlodipine has gone into price control. So companies are not making any money out of it. So they come up with some fancy newer calcium channel blockers at 5 times the cost of amlodipine.
So in spite of having so many issues, actually, in transferring Abhishek's messages and everything, we could conclude that, yes, the discretion is lying with the physician and cardiologist, what to use, when to use, how to use, and what dose and everything. So now we'll go to the next topic.
Jayesh bhai, before closing, I just want to thank you and Dr. Kamal bhai for giving me the opportunity.
But you are always welcome, and you have come in the dinner also today.
I am out, actually. I am from Delhi. Right now, I am sitting in Delhi.
There cannot be any excuse for you.
I am in Delhi, boss. I cannot come today. I will be reaching late. Thank you very much. Thank you very much, sir.
Thank you, Aril. Thank you all the speakers, Bhupen Bhai, Rashmit Bhai, Dr. Abhishek, all the panelists, Dr. Dharmin, and all the respected dignitaries, faculties, chairpersons. We move to next session.
This is
Thank you so much.
Sorry, kept you waiting.